Welcome to today's webinar hosted by First Focus on Children. My name is Elaine Dalpiaz, and I am Vice President for Health Systems at First Focus. Today's panel of experts will explain why the new 988 Suicide and Crisis Lifeline and mobile response systems need to be designed from the very beginning with children, teenagers, and young adults in mind. As the title of the webinar reminds us, one size does not fit all. This webinar is part of a week-long series of events to mark the one-year anniversary of the Sound the Alarm campaign to acknowledge the crisis in children's mental health in our country. I'd like to acknowledge Michelle Zabel and Melissa Schober of the University of Maryland School of Social Work for their leadership on the topic of 988 and crisis response systems for children and families. Finally, I want to thank our funders, the Robert Wood Johnson Foundation, the David and Lucille Packard Foundation, and the Annie E. Casey Foundation for their ongoing support of children's advocacy. Because this is a mini webinar and it's only 30 minutes long today, I will briefly introduce our panelists all at once, but you can find their complete bios on our website. And now I'm delighted to introduce our three panelists. Liz Manley is the Senior Advisor for Health and Behavioral Health Policy at the Institute for Innovation and Implementation, located within the University of Maryland School of Social Work. Liz is also the former Assistant Commissioner for the Children's Systems of Care in the state of New Jersey. Shamika Williams is the Director of Children, Youth, and Family Services at the Department of Mental Health and Substance Abuse Services in Oklahoma. And Tim Marshall is the Senior Advisor at the Institute for Innovation and Implementation, located within the University of Maryland School of Social Work. Tim is the former Director of Community Mental Health at the Department of Children and Families in Connecticut. Now, let me just go over three quick housekeeping details before we get started. Questions may be submitted from the audience in the Q&A chat function, and we've hoped to allocate about 10 minutes at the end of our session for Q&A. And yes, we will share our slides from today's webinar and a list of links to additional resources after the webinar with all of those who registered. And finally, the webinar is being recorded and we will post it on our website. So let's get started. Liz Manley, welcome.
Thank you, and thank you for having me today. I think the slides are coming up, right? So let's get started at the beginning. Children are different and their needs are different. And so as we think about crisis systems, it's really important to think about how children and families really need services and supports and when they need them. If you go to the next slide, that'd be great. So mobile response and stabilization is the way that we think about customization specifically for children. And it meets the unique needs of children, youth, and young adults. Next slide. And the way that that happens is really by addressing these developmental needs that young people have that are really different than adults, that recognize both their experience around particular trauma situations, their experience around things in school, the impact between children and families and how they interconnect, so that when children are having a good day, parents could be having a day. Parents stress systems may be elevated. When parents' stress systems are elevated, so are children. So these interconnecting pieces are really important in terms of what happens for children, youth, and young adults. And the role of the parent within the crisis and the crisis time is just really important for us to recognize. And service delivery systems really need to recognize that parents are part of what is happening, but also part of the solution. And they're really part of the mechanism for us to be able to see when children are beginning to struggle. That is true for children, youth, and young adults. And our ability to get there earlier really depends on the adults in the child's life. Next slide. So this is what mobile response and stabilization looks like. And I'll go through this pretty quickly and just say that the first part is the someone to contact. When we think about that, we think about when parents are learning their child is struggling and what might be happening for them. Our goal really is to answer the question for the parent, to actually be responsive. when parents pick up the phone and call a public system, to think about that. They pick up the phone and they call a public system and they say, I don't know what to do. My child is struggling, is a huge crisis situation to begin with. My friend Tim is probably going to talk about the peanut butter sandwich, but I'll just let you know that what's important is that parents don't do that unless there's something really significant going on. And what happens is if we don't see that, if other folks, who are answering the phone don't recognize the importance of that act by itself, then we miss opportunities in which we can really make a difference for children, youth, and young adults. So that someone to contact is really important, but it needs to be followed by someone to respond. 24/7, 365 days a week, the ability to see parents and say, we're going to hold your hand through this experience and we're going to help you figure out what to do is important, because our goal then is to build the competency of the parent and to build the their not only their experience, but to help them really understand that they can do this, that they can help manage what is happening for their child. And they can do that with the supports. They're more likely then to use the service delivery system as necessary. But one other part of this is really important, and that is that children and parents are not always ready at the same time for formal interventions. And what mobile response and stabilization does is it allow us to begin to sequence when and how formal services go into place so that they're more impactful and more successful, not just in the short term, but in the long term, as we look at success for children, not just in a 30-day window, but really over their lifetime. And then a system to support really talks about how do we connect the dots? So how do we provide stabilization for those children in their own homes, and really working hard to have them return back to school in a very quick succession, right? So making sure that the family has what it needs in order to be able to manage what's going on for that child and that youth. Next slide, please. Really, basics of mobile is this. We screen in, parents call, they ask for help, we go. Not complicated. We ask for help, parent says, I need something, we go. And because we go, we can actually eliminate the need for other really intentional high end services and supports in the long term. We see this in the states that have committed to 24/7 access to mobile response and stabilization. So it's really important for us to be able to do that. And the key components there for us to remember are that we have a workforce that's trained to work with young people. We have an assessment tool that is going to focus on what is necessary for the child and the family in order for their needs to be met. And we're going to figure out how to get children back into school in a very quick succession. Next slide. These are the core components, and they'll mirror some of the work around the adult system, around the 24-hour access to a call center. The difference in the call center is the triage doesn't look like we're going to actually say, yes, we're going to come, or no, we're going to come. The triage says, we're going to come. How do we get there? Right? Making sure that we know how to go there and that we're really understanding what the dynamics are within the home. That there's that 72-hour component is both about de-escalation, but also about assessment and making sure that we have a clear understanding about what the family's needs are. And that 8 weeks of stabilization, which is really important within this work, helps to support the parent and the young person as the young person returns to school, is engaged in community activities. And that care coordination component to stabilization is really impactful in trying to sequence when and how services and supports will go into place at the time that families can use them. Next slide. We're looking for interruption points, and those interruption points are really much, much earlier than when a young person gets to the emergency room, right? So it could be when the 15-year-old won't get off the sofa. It could be when the 10-year-old is beginning to struggle in school. It could be when that 8-year-old refuses to do something and the parent doesn't know what to do. It could be when the bullying happens where the child is bullied or becomes the bullier. But what's really important is the interruption points happening much, much sooner by helping all of the child serving systems know when and how to use the services and supports in a way that is meaningful. Next slide. These are the goals, right? The goal is to maintain a young person in their own home, schools, and communities. And I'll just give you one quick data point from New Jersey. 99% of the children who use mobile response and stabilization stay in their own bed. That includes children in foster care. That we support youth and families by providing trauma-informed care right up front. So we help families understand what trauma looks like and what tools can be used within the home to actually respond to those trauma situations. That we promote safe behavior in the home, school, and community. We reduce the over-reliance in emergency departments, hospital boarding, and detention centers due to the behavioral health crisis that currently exists, and that we assist youth and families in accessing and linking to ongoing support and services, including intensive clinical and in-home supports as necessary. I just wanted to touch real quick. You can go to the next slide. It's cool. I just want to touch real quick and letting you know that mobile response and stabilization is something that we've been working on for a very long time, right? So in 2016 to 2018, SAMHSA and the Institute for Innovation and Implementation partnered with Tim in Connecticut when I was the DCF assistant commissioner for the Children's Behavioral Health System. We partnered together with our friends from Wraparound Milwaukee to provide peer-to-peer support for all of these states who came to see. They did ride-alongs. They talked to all of us about the importance of this work. And many of these states are working very, very hard at implementation. I'm very, very happy to actually hand off to Shamika Williams, who's one of the states and one of those people who use this training opportunity to kick off in Oklahoma. Next slide. I think it's you. There we go.
Thank you, Liz, for that. Again, as mentioned earlier, I'm Shamika Williams. I'm the Director of Children, Youth, and Family Services for the Department of Mental Health in the state of Oklahoma. Next slide, please. Like Liz mentioned, we have a statewide infrastructure for mobile response and stabilization. We have our call center, which operates 24 hours a day, 7 days a week. We have mobile response treatment providers who are operating out of all 77 counties in the state of Oklahoma, who are able to respond to each situation, again, immediately within 1 hour across the state. Oklahoma is a large state. We're very much rural, frontier, and we have some urban areas. And so again, creating this platform that allows one single access point, immediate response and stabilization, and a pathway for actually helping children, youth, and families to stabilize. Next slide. Next slide, please. I think it's really important to really talk about what we know to be different in a children's system. Liz mentioned earlier, a crisis is defined by the caregiver and the youth and the young adult. I think that many of us, oftentimes we think about crisis as suicide attempts. We think about crisis, acute psychiatric behaviors. We think about crisis in the more extreme realm. But when we talk to families across the state nationally, really crisis has to be defined by a family. When a family says that they need help now, maybe because their kid won't get off the sofa, maybe because there's some truancy issues at school, people need to be able to respond. And that's why the system is a little different. Also, a crisis can be circumstantial. I think oftentimes families and young people do not have the ability to cope at that time in that moment. As an example, through COVID, families were at a high level of distress. And to be able to respond to families and in order to meet their needs and create a plan for stability is really important. And then also, oftentimes, youth and young adults do not have the skill set or the resources are not available in order to help them through that crisis moment. And so this is why a mobile response and stabilization system is really important. And we don't want behaviors to put youth at risk for self-harm, and we don't want behaviors to put youth at risk from being taken out of their home into a higher level of placement. And so we really want to work on strategies and ways to maintain stability at the community level, at the level where kids can maintain in their home as well as in their community. Next slide. I think it's really important to talk about our logic model. I think within our model, again, there's a single access point where anybody can call in order to get help for a young person from the age of 0 up to 25. This point of access doesn't require a payment source. Anybody can receive a mobile response across the state. We have some pretty specific objectives where we want to be able to approach people to get to them immediately. We want to be able to really navigate through the crisis system in order to, identify what is the situation. Make sure the young people get to the appropriate resources and help they need. We also want to partner with the community and other providers in order to provide those resources and help. And ultimately, our goal is to be able to stabilize. We stabilize from a systematic approach. We also look at ways so we can stabilize kids that are in juvenile justice or the child welfare system, kids that are in custody. Maybe the stabilization looks like a kid that is in state custody, maintaining in a foster home placement to prevent them from moving from home to home to home to home. Maybe stabilization is really working with the juvenile in the community to prevent them from going up to a detention center setting. And so customized stabilization is important. Liz mentioned the pathways to stabilization, really looking at those key factors across the population and providing services and supports that are specialized in those areas. Working with schools in order to create opportunities for kids to stabilize in those environments, really looking at those points of intervention in order to, again, create a disruption before things get to a crisis level, a higher level of acute option, such as an acute setting or a residential setting. So really creating pathways to divert that. And then reducing the number of kids that go into hospitalization. Oftentimes that reduction, families, when they need help, they utilize the emergency room, and creating a pathway where we can divert kids from emergency room options, which oftentimes leads them up to an acute setting. I said this, and I've said this 1,000 times, and I think it will be important to say it again today. There's only one option that oftentimes there's only one place that kids can be disconnected from their parents. That is in a psychiatric placement. If you took your kid to an emergency room, you can be with your child from the point of emergency room all the way up and to the ICU, if that is the case. And so really creating those point of interventions. We do believe that there are times when kids need acute settings, but we also believe that if we can intervene early, we can prevent that type of trauma from happening. Next slide, please. We also learned that there are some, in the customization, there are also points that we can intervene and really create temporary break-in in situations in the crisis. We also believe in respite options as placement change. Oftentimes young people, when they're at the height, young people escalate up very quickly, but they will also come down very quickly. And so if we can create points of intervention, given options such as respite options to create temporary breaks, we can possibly stabilize that young person in the community. We also believe that if we can intervene and really work with our child welfare partners, we can create stabilization in young people in foster homes. It's also important to understand that really working to customize the design for that youth, that child, and that family is really important. And so respite is definitely a lesson learned and an option for the children's system in order to create opportunities for stabilization. And then also really working from an informal and a formal approach to really make these processes work. Sometimes it's the neighbor, sometimes it's the aunt, sometimes it's a family friend that can help in a crisis situation. And so it's really important for a children's mobile response to look at the avenues of the resources that they have and collectively utilize those resources to work on behalf of the family. And sometimes respite is a great option when in fact families are in crisis. Next slide, please. It is also important to really look at factors on down the line. What we know is from 2019 to 2022, we had over 2,034 young people who had experienced a crisis. What we also know is when we're able to get those young people in the services and support quickly, we're able to, one, increase the outcome for those young people. We had about 75% of those 2,000 youth that were significantly impaired. That means that they had a level of impairment that was affecting the behaviors that created the crisis. What we also know is once we're able to get those young people the resources and the support that they need. Now, the 2,032 are not all the youth that we served in our crisis system, but those were the youth that we were able to bring into services where we actually have a system of care providing wraparound services. And we were able to reduce 52% of those kids and help them to get back to a level of stabilization that showed clinically significant improvement. And so what we know to be true is that when in fact young people have access to services and supports, things change, improvements happen, outcomes are greater, kids are able to stabilize and maintain in their home. So creating a system where you have not just a response, but a way to support youth and families in the community is significantly important. Next slide. It is also important to really talk about the lessons learned. Within our system, we have specific points of entry where we look at the OR quality assurance, and we look at data factors that really help us to make changes, to redesign, to make our system better. So as an example, 78% of calls reported that they would use our crisis call center again. It wasn't just important to know that 78% would use our call center again. We wanted to know why. What was the factors associated with their utilization? What were the success factors? What can we improve on? What can we do in order to really make that initial response, that initial call, supportive in a way where families would want to call again, or supportive in a way that they know that they had a person that was willing to help. We know that 71% of recalls report that the crisis was resolved. That's really extremely important. We're talking about close to 20,000 young people. 71% of the callers report that the crisis was resolved. What did that mean? That means that they were able to get the help, the support that they needed in order to help to move forward with stabilization of their young person. 74% of the calls report that their experience with the crisis call center was good or great. Again, that is an important factor because that initial call, when a parent says, I need help and I need help now, our ability to respond and engage in a way where parents or caregivers are able to get the support is critically important. Why is it important that the call center and the crisis responders and people have a success? Because what we know, if we can create a success, they're more likely to utilize us instead of utilizing the front door of an emergency room. They're more likely to get help when they want it instead of waiting until we get to an acute crisis state. And so those things are really important. And then also really reporting progress since the call. 73% of the almost 20,000 youth reported a progress. That means we were able to connect them to a provider that can continue to maintain the support that they needed. We were able to connect them to the resources that were able to maintain the resources they needed. And then also we were able to build out a system that provided pivotal points of intervention to successfully help the different populations of youth that were calling our call center and utilizing our call center. Pretty important. Again, when parents need help, they want caregivers, parents need help, they want help now. So those are pretty important lessons for us. Next slide, please. Again, this last slide is really to give some credit to our University of Oklahoma E-team who manage our data system. We have a real-time data system that provides real-time information about the call, the nature of the call, and then also those longitudinal outcomes that you want to see. How are we able to stabilize kids within our system? And how are these kids doing months out, years out? And so that's pretty important. So kudos to the University of Oklahoma E-team for the data that they produce for the state of Oklahoma. All right, and I think I'm turning it over to Tim Marshall.
Good afternoon, everybody. You go to the next slide and the next slide after that. Good to see everybody, and I'll just reiterate a couple of points. One, that children are not little adults. So what we mean by that is you just can't take what you do for the adult system and apply it to kids. And we had that experience in Connecticut. One of the main drivers, so Connecticut has a very mature mobile crisis system, 13 years old. We've had a lot of success in this model that we're presenting. And the main driver for this was when I took over the service in 2002. The first 2 years, I heard from parents over and over and over again that they stopped using mobile crisis because when they called, mobile teams did not come to assess them. And that was with a 50% mobile response rate. So that was a 50-50 chance that you would get a response. And so that there was a lot of telephonic counseling out, if you will. That is, we can count you on the phone, but it's not important enough for us to come out. So that was one of the biggest complaints that made us decide to change our model. The other 3 or 4 points under the complaints really came out of a variety of complaints around different ways of doing the work. There was a lot of inconsistency with EDs and police and schools. A lot of our providers were telling us that they could manage things that they were not able to manage. Then we didn't really know that until we got on top of that. And there was limited capacity. So the goals are there on the right that we set out when we were to reprocure this. And it took us 2 years, and we really worked hard on setting the model for those 2 years, and then rolled out the new model in 2009 or late 2008. So those goals are there. You can see those, and they are consistent with what you've heard already. The next slide, please. And so this is what we wanted to do. We wanted to be responsive to the complaint. So we wanted to be responsive. And what we made the decision is that we are not buying a crisis assessment triage process, that what we are buying as a state was a face-to-face assessment for kids. One of the things that's significantly different for children as it is for adults is that most callers to an adult line are the adult that's in crisis themselves. That's not always the case, but most commonly it is. On the child side, most callers are the parent or caring adult. And sometimes that caller doesn't really know accurately what's necessarily going on. With due respect to that call, again, parents, teachers, other people, but sometimes it's hard to really get an idea of what's going on when there's a situation that warrants a crisis. So that was one of the reasons why we wanted to make sure we were going to see the kid face to face and do an assessment. We wanted to be quick. Our benchmark in Connecticut is 45 minutes, but we're average face to face in 30 minutes. We wanted to be sure we listen to the caller. And what we mean by that, it's not just what's being said. Liz made reference, we had a really important turning around point with the managers that were providing the service both before our model that allowed them to triage calls telephonically to decide whether or not they should go face to face or not, versus that when we, with the new model, and we said, we want you to go out. And that was when a manager reported that they received a call from a mother who was emotional after lunch, and her complaint was her child wouldn't eat the peanut butter and jelly sandwich. We did not say what's going on. We did not get underneath that. We said we're on the way, and we went. And when they arrived, they found that it really was the tip of the iceberg. The mother was emotional for a variety of reasons, and just not eating the peanut butter and jelly sandwich was the trigger for that day. So that's one of the reasons we feel strongly about the face-to-face assessment. Structured, consistent, evidence-based practice-like model. We really wanted to model fidelity. We wanted to be consistent across the state. We wanted to have structure, and we wanted to have strong benchmarks. The reassure the caller, yes, we're just going, we're just on the way. So we just need to know, is there any dogs? Is there specific issues around safety? Where are we going? Is it, in an apartment building? Those kinds of questions. And then linkage and connection. We wanted to be sure that after the acute crisis was settled, what is the long-term care, and how could the system work for the family? Next slide, please. So these are our core elements. We have a statewide call center. We used our 211 informational referral, and what allows you to jump the queue to get picked up within 5 or 6 seconds is you hit 1 and you hit 1 again. Connecticut now has an integrated approach after implementing 988, and all of our call specialists for 988 are fully trained to warm transfer right to the child mobile crisis or the adult mobile crisis in the state of Connecticut with no transfer to any other queue. So we wanted that core, we have that core element. We wanted this to be community-based. We wanted it strength-based and really centered around family needs. So it's not, as Liz said and Shamika referred to, it's not just about the child in crisis, it's around the whole entire family. And there's no better way to get a sense of what's happening there other than going face to face. We wanted it to be free of charge. That is, it's open for all kids in the state of Connecticut, regardless of insurance, uninsured status, privately insured, commercially insured, Medicaid insured. Everybody is covered. And if you happen to have Medicaid or commercial insurance, our providers may also be able to bill. We wanted the face-to-face acute stabilization to occur within that rapid time. And then after that acute crisis is stabilized, we wanted to make sure there was a linkage to the ongoing most appropriate services that met the needs of the child and the family in need. We wanted master's level prepared folks who know how to manage crisis, and we train them in a lot of specialty areas. And we work really, really hard on an annual basis to keep all of the competencies and skills very sharp for all of the crisis clinicians. We do allow for the use of peers, but a lot of our providers haven't made themselves available to that. And then finally, we wanted to be sure that quality was the number one thing and that we had a data-driven system. So we also contracted with an independent person to help us manage the entire system, both the call system and all the contractors. Next slide, please. And finally, so here's a summary of our lessons learned in Connecticut, not unlike Oklahoma. We believe it's really important to engage and include parents and caregivers and in youth in this whole, and family members in this whole process. And when you talk to kids and families, what they'll tell you is, if I'm calling a stranger, I need help, and I need help now. And so we need really to be responsive. And if you don't believe us as a result of this presentation, just ask the youth and family members. You need to engage all the community providers. You need to engage your hospital association and hospitals and EDs. You need to engage law enforcement, but you also need to engage all the community mental health providers, the behavioral health system, and the schools in particular. Again, this notion that you need a single point of access. We had 12 different points of access. We were told that our providers had the ability to handle multiple calls at once, and it turned out that very few of them actually had that ability. They all use different crisis assessments, and so we standardized that by engaging them in the process of coming up with a single statewide uniform crisis assessment document and process for intervention. And we wanted to build that connection and linkages to long-term services. So in summary, be responsive, get face-to-face, be quick, and be strength-based. And that's my presentation on Connecticut, and thank you all.
Right. Thank you, Tim. That was terrific. And thanks to all of our panelists for sharing your unique experiences and your insights from years and years on this topic. I can speak for myself and probably many of you that I think now we have a much better sense of what an effective crisis mobile response system should look like for children, and the importance of having an effective 988 call system. And Tim, as you said, children are not little adults, and that's something we often say at First Focus on Children. So now I'll turn the webinar over to my colleague, Avery Bakulis of the First Focus Health Policy Team, and she will lead the Q&A discussion.
Thanks, Elaine, and thanks to all of our panelists so much. We've just got a few minutes left here, so I would love to run through a couple of questions, and I'll start with Liz. So I'd like to talk about the federal government's role in crisis response and the 988 systems that are being set up. We understand that SAMHSA at HHS has been working on some guidance to states on how best to prepare for a crisis response for children and youth and their families. The guidance has not yet come out, but we are waiting for that. In addition to that guidance, what else is the federal government's role in ensuring that we have tailored crisis response systems for children and their families?
It's a great question. I think we start by letting the federal government take the lead in terms of bringing folks together and saying, this is what it looks like, and helping in providing training and technical assistance around what is different for children, what is necessary for children, and in order to ensure that they are able to meet the needs. I mean, listen, the 50 states all look different in their service design, and so it's really helpful when the federal government says that these components, these core components, are really helpful and can make the connection not just to the short term in the data collection around what happens today. I mean, it's really helpful to know that the child stayed in their own bed. The question is, did they stay in their own bed at 6 months, at 12 months? Did they touch on child welfare? Did they touch on juvenile justice? And so the federal government, because they have the ability to connect to all those systems, could be really helpful in providing support to states as they're trying to build, and then help states figure out when it's necessary to innovate in the way that Oklahoma has innovated to meet its needs around, the rural communities and frontier communities in Oklahoma, as just an example.
Thanks, Liz. I think that's such an important point to make, that in these systems you all are working so hard on, you're looking at the long-term impacts on children and their families. It's an immediate response, but it's also long-term, and the federal government certainly has a role in a variety of players in that continuum. And actually, you led me perfectly into my next question for Shamika, which is to ask about the challenges that Oklahoma faces and other more rural states face in providing crisis services to those more rural parts of your state. And how have you in Oklahoma been able to address those challenges and mitigate some of them?
So, so we're talking a state that's like Oklahoma, and we're very rural and frontier in our state. And so customization for us kind of looks like this, and for the fortunate thing for the state of Oklahoma, we started utilizing technology earlier. We started utilizing ways to interact across the state in real places. Oklahoma is really big on iPad technology, where we're able to utilize that face-to-face option. So we actually train and equip first responders, especially when in fact we have law enforcement officers who are going to respond to the immediate needs of youth and families when in fact it is a safety issue. If it is a safety issue, we prefer to have a CIT officer who responds that we've trained. We also prefer that that officer has an iPad technology to interface with the behavioral health practitioner to be able to be that immediate person who is supporting that young person. We know across the state that our law enforcement officers are extremely busy. So we don't necessarily want them to respond. We want to be the responder, but we also know that in times they're going to be the respondent. And so when that happens, we want to give them the tools and the equipment to utilize to interface with that behavioral health practitioner. And so for us as a state, the size of the state of Oklahoma, large in proximity, frontier and rural, it is important to implement strategies around technology. It is important to implement strategies around training. It is important to interface with our small rural hospitals and our rural communities in order to educate them about children's behavioral health. And so those are some of the strategies that we have been utilizing in order to be successful.
Thank you, Shamika. We did get a question in the Q&A. Thank you so much to Dennis Barrett, who is wondering what kind of support or other cultural competencies exist to support children of marginalized identities, such as Black or LGBTQ youth, who may be calling for themselves instead of a parent or other adult. Does anyone want to jump in here and talk about responses to specific populations of kids?
Let me just jump up in real quick, and then other folks might want to add. But the first thing is that we want to make sure our mobile response teams understand the communities that they serve and that they have real clarity on how to do that. So lots of training and support to those teams so they really know how to engage communities. We're really looking for understanding not just who's coming to us, but really going into the communities to figure out who's not and why not. The other thing I wanted to just say in that is in the good and mature, good modern systems, right? Parents actually become more responsive because they're responded to, right? So they begin to see changes in their children earlier, and they get help when they call. They're more likely to reach back out, even when there are challenges with their understanding around the child's identity and the child's, maybe not agreement in terms of how to move forward. They're more likely to still use the system and more likely to work through because of the positive impact that they've had. Because when they called when their child was 5 and they got good response, they're actually more likely to call when there's challenges around. And one other point I just wanted to make, I was in the state yesterday that's working on implementation of mobile response and stabilization. They're in early implementation, and one of the surprising factors for them was that in the communities of colors, parents were more likely to use mobile response and stabilization because they didn't feel the stigma of what it was like to reach out to another system.
Right. And I want to add to what Liz said, because again, I think customization is really customizing around the population. And so when we talk about Black and brown kids, we really have to work in those communities with key individuals that know those communities better. We did this thing with barbershops and beauty shops in some of our African-American teams, where we equip those individuals with knowledge around children's mental health. We utilize mental health first aid and other trainings to educate them about when kids go into crisis, what does that look like? When families need help, what does that look like? And how can we be your responder? What do we need to know about your population? Another population is Oklahoma is extremely rich in native population. We have 36 federally recognized tribes across the state. It is really important for us to work with each of our tribal partners to know how we respond to your citizens, and what does that need to look like, and how can you be a part of that responding. And so again, I think it's important to customize and engage based on your population, whether we're talking about age, gender, whether we're talking about race, whether we're talking about population of kids in custody, whether we're talking about, again, and create different means of engagement to meet the needs of those populations.
Thanks, Shamika. I know we're running a couple minutes over here, but we've just got some really great questions. So I'm going to go for a few more minutes. For anyone who has to drop off, feel free. But two really important points that were brought up in the chat. One about the avoiding the use of or the response of law enforcement. And that is certainly one of the major goals of the new 988 number and of mobile crisis response. Tim or anyone else, would you want to talk about your experience and how that is a really major piece of what you're trying to do?
Yeah, first of all, we should acknowledge that law enforcement try really hard and do a great job as best they can with mental health. That being said, it's not the primary place where we want mental health to be dealt with by law enforcement. In Connecticut, we really took two major strategies. One, it's earning credibility with one police department, one police officer at a time at times, and that you have to demonstrate credibility working with them. And some of that will come out over time. But and what we require and ask our providers to do is to get to know every law enforcement, every police department that they have in their jurisdiction as much as possible, and preferably exchange cell phone numbers, particularly at the management level or at the administrative level. But one strategy that worked really well in Connecticut, we employed, it's not just the CIT training that law enforcement use. We also have a CITY, the youth convert portion of that. In that actual training, we, the mobile crisis management team, co-trains with law enforcement in that module. It's in another 2-day module. And when we have done that, what we have found is the secondary gain of working alongside by side of law enforcement has really developed a trust and a working relationship. So it's those informal connections, and we work hard at it. We actually have a greatest working relationship with Cable. It's the police association, the training arm of them that we work with closely also on educating them on what we are able to do.
Thanks, Tim. And then one last question I want to squeeze in here because I think it's so important in the youth mental health space. And that's the issue of shortage of providers, all sorts of providers. And we have a participant who is reporting that in Texas, there's a lack of available counselors, psychiatrists, other providers. And I imagine that is happening in all of your states. And would someone speak to that and how that is, I mean, a huge need across the board, avoiding unnecessary emergency room department visits, and what you're seeing on the ground as far as providers and any shortages?
Yeah, two things I'll just put out there that I think are important. One is that one of the powers of mobile response and stabilization is it doesn't need to be delivered by a clinician, right? So we can train bachelor's prepared and peer support folks, individuals with lived experience, to actually do a lot of the work, and moves the clinicians into the supervisory position of ensuring that their support training and all of the other things that are necessary to make sure those teams are well taken care of. That is the model that existed in New Jersey for now 20 years. So with great success. Two, I think it's really important that the role that people understand that mobile response and stabilization is about setting the stage for those formal interventions. And so we're not meeting with children and then saying everyone goes to outpatient, right? A good majority of those young people aren't going to need outpatient care or aren't ready for outpatient care quite yet. It's really about the reconnection with the schools, reconnection with the community, and making sure young people are supported by the adults in their life that really make the difference in the short term. And because of that, we actually reduce the over-reliance on every child going to outpatient care as the first. And so we can shorten those wait lists so that the psychiatrists and the clinicians are actually now seeing children who are more prepared for those interventions.
Thanks so much, Liz.
And just to add to what Liz said, I think that really states really need to look at the investing in peer supports, non-degree professionals as well as bachelor's level professionals. I think those degree professionals, licensed clinicians, psychiatrists, I mean, they're extremely needed. But right now, with workforce around the nation, we're going to have to really step back and reinvest in those non-degree and bachelor's level positions in order to tackle this workforce issue we have across the nation.
Thank you all so much. Tim, did you want to jump in? I just saw you take yourself off mute.
Well, no, I'm okay. Thanks.
Okay. I'm so sorry. We have run out of time. I think we could go on for a long time here. But I want to thank everyone who attended. And a sincere thank you to Liz, Shamika, and Tim for joining us, for sharing your incredible expertise. And a thanks as far as the First Focus team to our colleagues, Olivia Gomez, Tim Smith, Michelle Kale, and Jake Espinal for your help in producing today's webinar. And we will follow up with everyone who joined us today and everyone who registered with slides, with a recording of this webinar, as well as some other resources our panelists have shared. So thank you all so much, and we look forward to seeing you soon.
Thanks. Bye-bye.